Asia. Mabuhay! I am Mela Habijan, your Miss Trans Global 2020, and it's an honor to host this remarkable collaboration on Pride Month. So happy Pride, everyone, to all those watching at home. And this is between the International AIDS Society and Love Yourself Incorporated of the Philippines, two organizations at the forefront of addressing the HIV/AIDS epidemic. The You Matter Symposium is a 2-day event with 4 sessions tackling solutions to regional challenges on HIV/AIDS through open discussions and learning sessions. This afternoon, we have session 1, Upscale PrEP and PEP Interventions, and session 2, Understanding and Unity Against HIV. Tomorrow, June 4, we will have session 3, You Live Healthier and with Treatment, and session 4, You Leverage on HIV Self-Testing. Now, to formally open the You Matter Inspiring a Client-Centered HIV Response in the Philippines and Southeast Asia Symposium, let's all welcome the IAS 2021 International Co-Chair, the Dean of Medicine and Professor of Infectious Diseases under the University of Malaya, Malaysia, and the International AIDS Society President, Adiba Kamarul Zaman, for her welcoming remarks.
Mabuhay and good evening, dear colleagues and participants of the International AIDS Society Educational Fund Symposia, organized in collaboration with Love Yourself. The theme of our symposia is You Matter, inspiring a client-centered HIV response in the Philippines and Southeast Asia. Asia and the Pacific region is home to an estimated 5.8 million people living with HIV in 2019. It is increasingly clear that the region is falling behind regions in Africa in our HIV response, unfortunately. In 2019, an estimated 75% of people living with HIV in this region were aware of their status, and amongst those, 80% were on treatment, of which 91% were virally suppressed. However, I think many of you would probably agree with me that these figures probably represent an overestimation. The epidemic is largely characterized by concentrated and growing epidemics in key populations in a variety of countries, particularly clients of sex workers and other sexual partners of key populations, people who inject drugs, and men who have sex with men. Low national prevalence masks much higher prevalence amongst these groups and in specific locations, particularly in urban areas. In 2019 alone, 300,000 people became infected with HIV in Asia and the Pacific, and 3/4 of these infections occurred amongst key population in our region. Although new infections declined by 9% between 2010 and 2018, progress has been slowed in recent years, and new infections are on the rise in some countries, including Bangladesh, the Philippines, Pakistan, and even Malaysia. And this, dear colleagues, was even before the COVID pandemic complicated matters even more. So with this in mind, this symposium aims to discuss the main challenges and recent updates on the HIV response in Southeast Asia. And during 3rd and 4th of June, the 4 main topics that we will cover during this meeting will include scaling up PrEP and PrEP interventions, understanding and unity against HIV, particularly focusing on HIV, stigma, PrEP, and U equals U. You Live Healthier with Treatment will be a focus of discussion, and finally, You Leveraging on HIV Self-Testing with country case studies and self-testing in the region. Now, we hope that this symposium will meet your expectations and catalyze further actions and activities in the Philippines and in the region to implement the latest knowledge and science to advance the HIV response in the Philippines and in our respective countries. We hope that by sharing best practices for the advancement of HIV prevention and treatment programs, we will improve the HIV response in Southeast Asia in the coming years. Please do enjoy, and we hope that you will gain much knowledge and experience from this Symposium.
Thank you very much, Professor Adiba, for your very warm welcome to all of our participants. Definitely, on a personal level, I'm so excited to be hearing insights from our panelists tomorrow. So now, to discuss the agenda and the meeting expectations, let's all welcome Love Yourself Incorporated founder and executive director, Ronivin Pagtakhan.
Greetings. My name is Taufik Bakani and I'm Senior Regional Strategic Information Advisor with UNAIDS Regional Office for Asia and the Pacific, and I'm based in Bangkok. I am pleased to join you today and share some perspectives and reflections regarding the HIV situation in Asia and the Pacific region. I should clarify that I will be mostly referring to a 2020 round of reporting for 2019, simply because the new round of reporting is still not completely available at this stage. I think it is not news to anyone to say that we have missed the global target of reducing new HIV infections as initially set in the global fast track strategy. In Asia and the Pacific, we have only achieved about 12% decline of new infections compared to 2010, which is about half the global performance, showing that we are much behind. At 300,000 new infections per year, we are very far from the initial target set for achieving 90,000 infections per year. As you can see, this global picture hides a big variety and very large differences between countries in the region. We do have some countries achieving extremely well in reducing new infections, as you can see in the left side of the top graph: Singapore, Vietnam, Thailand, Nepal, and so on, managing to have substantial declines of new HIV infections. At the same time, this is being countered by very rapid increases of new infections in a number of countries, where everybody knows that we have a country with the highest increase of new infections in the world. Same thing can be told about the reduction of AIDS-related deaths, reflecting a very wide variety of success in the treatment program and ability to save deaths, whereas you can see we have rapidly increasing rate of mortality, AIDS-related deaths in a number of countries, including Pakistan and the Philippines, compared to good savings of lives and a very substantial reduction of AIDS-related deaths in India, Australia, Cambodia, and others, particularly those who are achieving very well in their treatment cascade. So we all know that the epidemic in Asia and the Pacific is very much affecting key populations. It's mostly affecting key populations. 98% of the infections in our region are among key populations and their clients and the clients of the sex workers and partners. Key populations here, we mean sex workers, people who inject drugs, men who have sex with men, and transgender. It is worth noting the very large share of infections among men who have sex with men, at 44% for the region. And this share is growing almost in all countries, regardless of the trend of new infections in that country, reflecting that either the epidemic is growing among that population, or where there is a success, the success is not achieved as well as it is for this population compared to others. The analysis, specifically for the young populations aged 15 and 24, reflects a very similar picture. 99% of the infections are among these populations, but it is notable to say that over half of all the infections are due to male-to-male sex, meaning affecting men who have sex with men. So here it's important to start looking at prevention. Considering all these situations, when we know all infections are affecting key populations, we would expect that the prevention programs would target mostly these populations. This graph tells us information reflecting prevention coverage by country for each of the populations. That populations are reflected by different colors of the dots, as you can see, female sex workers, MSM, and transgender. But you can observe in general, without getting to the details, that most of the dots cloud is more toward the left side, less than 50%. If we single out, for example, men who have sex with men in our region, considering that they represent 44% of infections in our region, you see that all the red dots are more to the left side, representing very low coverage. And this means that the regional median are extremely low at 25, 26, 39, 45% coverage. We are not doing well in prevention, and we cannot expect having a major impact on the epidemic without that. We do not a good interest and big vibes around uptake of PrEP. We have the evidence from within the region, coming from Australia, New Zealand, and others, that PrEP, when implemented at large scale, can be extremely effective in reducing new infections. Unfortunately, we still do not have much of the uptake at national scale in the region, and we do realize that we have 4 countries, for example, who have adopted PrEP as national rollouts: Thailand, Cambodia, and Vietnam. Others are still in phases of pilots, demonstration, or still in planning phase. And the resulting situation is we do not have large number of key populations on PrEP, which would lead to a major impact. So it's good to have good adoption of good initiatives, good models that are effective, but it's worrying to see a very slow scale up that make us miss the opportunity to achieve a major impact on the epidemic. Looking at the HIV testing uptake, same situation happened. We are in the mid 50s, in around 50% coverage in the regional median, and you can see the spread where uptake of HIV testing is as low as 10%, for example, for MSM, and the best performance we see in a country is 80%. The variety, the very large spread of those dots reflects the level of performance with regard to HIV testing uptake. So it becomes interesting then to analyze why. We all know the challenges and the issues around stigma and discrimination and all kinds of barriers that are pushing, that are limiting for key populations to access services. But if we look specifically at young people, and we do consider the legal and institutional limitations and barriers that prevent them from accessing HIV testing, as you can see here, all kinds of requirements of consent, limiting those individuals to access testing just is one factor leading to that low uptake of HIV testing. Speaking of young people, and this slide really reflects different pieces of information that tells us how young people are extremely vulnerable to HIV. We have many countries with about 50%, about half of all the infections happening in the country are happening among the young people, 15-24. We see many countries, as you can see at the top left side of this graph, with an increasing trend of new infections among young people. And this is associated to evidence coming from a number of countries with a very rapid and very high increase of prevalence among these populations, reflecting a very high incidence. At the same time, you can see the bottom right corner of this slide that we have lots of limitations still, not allowing these young people to access HIV testing and access testing, or at least from there using it as an entry point to prevention. So looking at the different options and modalities available for HIV testing, we do realize that there is still a long way to go in adopting a variety of models for HIV testing. Yes, 50% adopting community, and that's only 50%, about 53% community-based testing. And at the same time, we only have 4 countries allowing for national policy or national adoption of HIV self-testing. And for our case, I would like to mention here Cambodia, China, Laos, PDR, and Nepal. So when we analyze the effect of these combination on the impact of testing, we realize we have major data gaps, unfortunately, but we have sufficient to single out, for example, to see that Nepal and Cambodia, who have allowed self-testing as national policy, are among those who are achieving the best performance in HIV detection, about 300 HIV detection per 100 infections. 3 times more detections than infections happening in the country, which means they are closing the gap on the epidemic. And as you can see, then leading in the right side, them to having much better rates of ART initiation as compared to new infections, which would lead to closing the 1990 gap. Countries who are not able to scale up HIV detection will not be able to scale up new ART initiation, and of course not able to close the 1990 cascade gap. And this is reflected here in this slide, as you can see, where we have some countries achieving very well. And as you can see, Thailand and Cambodia and Nepal is catching up, and Vietnam and Singapore doing very well in with regard to the treatment coverage, and others are lagging behind. The main issue for that is HIV testing, uptake, and case detection. So I do think it is very important at this stage to refer to the growing trend of use of social media, online and mobile-based platform for finding sexual partners. We have evidence in several countries that this is associated to very high incidence, simply because these online platforms facilitate for high-risk encounters. It's very good to note that we have a very large variety of models and very large number of models online based, using virtual interventions for service delivery, and they are of different kinds. Phone-based counseling, social media posting, cohort tracking, online assisted testing, online based outreach, virtual doctor consultations. We have several models. Unfortunately, these remain relatively at small scale and not implemented large enough as national strategies, national policies, reaching very large numbers to allowing them to achieve a good impact. So there is definitely a very strong potential to strengthen these models of interventions in the region, considering the ability that they provide for reaching those who remain hidden, hard to reach, or will not be able to access the traditional facility-based kind of service. So I do believe you all are aware of the new global HIV strategy recently adopted, and its principles and its approach, focusing on the services, on the systems, and on the enablers as 3 main pillars, and other cross-cutting issues that need to be addressed comprehensively. But I would like to highlight mostly what this strategy had brought up, which is the focus on the inequalities lens across all the strategic priorities to ensure that no one is left behind. It is extremely important to highlight this specific point on keeping people at the center to ensure that they benefit from the services, to remove the social and structural barriers that prevent people from accessing HIV services, which is a game changer and very important toward achieving impact. Our regional adaptation or our regional specificities being accounted in that strategy reflects that on these recommendations that we need to renew and intensify the focus of policies and programs on rights-based approach. More importantly, modernize HIV service delivery using innovations, including scale-up of PrEP, self-testing, multi-month dispensing, and the use of virtual spaces, eliminating barriers to equitable service coverage among the most marginalized, and mobilizing sustainable domestic financing for prevention. These are key, and as you can see, you could see from the evidence provided, these are really important if we want to move forward on strengthening the response and achieving impact and meeting the new targets are being set for the new strategy. So thank you very much for your attention.
Definitely, that is not our dear friend Ronnie Vin, but that is our very first esteemed speaker, the Senior Regional Strategic Information Advisor of the UNAIDS Asia and the Pacific, Taufik Bakali, for the session 1 of Upscale PrEP and PEP interventions. And right now, we will be talking to him so as he could answer your questions, which you can, by the way, just make sure you type in your questions, because we will make sure that the questions that you will be asking will be addressed to all of our speakers this afternoon. So without further ado, hi Taufik, sawadee ka.
Hello, good afternoon. Nice to hear you. Nice to join this beautiful gathering.
Yes, thank you for gracing this event with your presence. Definitely, we've learned so many things about the current situation of HIV/AIDS here in Southeast Asia. And there are so many questions that we've gathered from our audience right now. And the first question is, how can countries in Southeast Asia be more aggressive in promoting the concept of treatment and prevention?
Treatment as prevention. There are different ways. And first of all is a need to try to address the existing bottlenecks. It's really important. Treatment as prevention is not a principle. And it's not something that you would say we will find our way around the epidemic with scaling up treatment. We have several issues. Of course, there are medical type of intervention, and PrEP is definitely one of them. As you all know, PrEP is the treatment drug, but it helps in preventing the infections among those who are most vulnerable to it. But when we see the different policy, structural, and design challenges in implementing PrEP at large scale, we cannot talk about PrEP as a prevention when the implementation is at very small scale, reaching few thousand individuals per project. It has to reach a high level. And for us, what we are looking forward to is relatively large numbers to allow for having an impact on the epidemic. Yes, there are individual benefits, even for 100 people, but we want to see the impact on the overall epidemic, and that requires large numbers. When it comes to treatment coverage, that particularly achieving a viral load suppression for people who are living with HIV, the situation becomes a little bit more complicated because there are several factors that come in. First, you need to find those people, and we need to adopt the strategies with regard to HIV testing so that we can identify the maximum in the shortest of time. Treatment cannot serve as prevention with a coverage of 20% or 30% or even 50%. It has to reach very high level of treatment coverage so that we can see the general herd immunity, as now we are talking about these in the time of COVID. And it's not sufficient only to say we have this number of people on treatment or this percentage, when we know, as we see in several countries in this region, there are very high levels of dropout and loss to follow up, and people discontinue for 3 months and come back again for another 2 months and discontinue treatment. It has a negative effect, not only in leading to higher deaths, but in reducing the chances to have high levels of viral load suppression, which would lead to that preventive effect at community level. Commitment is beyond the political and the financial, it has to be pragmatic and programmatic in finding the ways on how to resolve all those challenges throughout the prevention and treatment cascade, I would like to say.
Thank you very much for that, for those insights, Taufik. I definitely agree with you that for treatment as prevention to be impactful, I think there is a need for countries to implement policies on a national level. And that being said, how do you think can governments speed up the scaling up of self-testing programs in Southeast Asia to reach more untapped key populations?
There are several aspects coming into it, and there are reflections and maybe we can say genuine worries in terms of managing what happens when a person finds him or herself living with HIV through a self-testing. There are lots of worries that on the official side that we cannot monitor, we cannot manage, we cannot ensure the immediate linkage and all these things, but we have solutions, practical solutions, and we have the information from the community organizations who say, yes, this at least will help us overcome the existing challenges with regard to stigma and discrimination and maybe other kind of difficulties in accessing testing in physical or in venue-based settings. So beyond the policy, there is a need to find the specific models to allow for this to work. And it's not to say people go to the pharmacy and buy self-testing and do the test themselves, and then they take their own decision to go for treatment. There are different ways to assist that process, and we have seen in several countries here peer-assisted. We have seen online-assisted testing, which respects the all the aspects of confidentiality and all these things. And we have seen there are 3 or 4, at least, that I'm aware of, different models, and I'm sure there could be more, where self-testing is not completely independent from any kind of support, which facilitates the links, facilitates the counseling, facilitates the quality assurance, facilitate the links for confirmation of the test, since this is mostly only not confirmatory, and also making the links for the access to treatment. And all these aspects need to be considered and rapidly adopted and implemented if we want to see the relevant impact. Small projects in specific venues is not sufficient, except for demonstrating that, yes, it works, which is something we know already.
These are very exciting steps, and I hope we can work hand in hand into implementing these small steps, because such small steps are integral so that we can truly fight and achieve that dream by 2030. Now, on to our next question. Which virtual intervention has been most successful in the Asia Pacific region, Taufik?
Very difficult to single out one, but any virtual intervention is useful as long as it enables to reach those who are mostly not able to access or are more likely not to access the physical intervention. And the variety and the richness is the strength, right? So we cannot say use mobile app and that's it. You will be able to reach everyone. And that variety provides the options for and responds to the needs of specific subcategories, whether it's young people, whether it's specific community, whether it's specific group, whether it's sex workers or men who have sex with men or transgender, and how this mobile or online or virtual approach and model helps to respond to specific needs, but also makes the links towards providing a service. And since not everyone needs a service in the same way, at the same time, my personal stand is we cannot think and single out one specific model. We need that variety so that it helps responding to the needs of different categories of the population and on their different profiles and specificities and maybe locations. Maybe a virtual intervention in the Philippines should not be the same, even if it works very well, should not be the same when implemented in Indonesia or in India, just because the settings are different and the recommendations and the links from that virtual model would be different. But as long as it serves the purpose of responding to a need of specific populations or specific individuals even, towards accessing those services, this is what we are looking for. And my stand remains that that variety of models provides the richness and better guarantee for success.
I love how you framed it, Taufik. I definitely agree with you because we are a diversely beautiful population of people, and a variety of ways in addressing the HIV/AIDS epidemic is definitely crucial so that we can cater to a massive number. And definitely, I'm also with you when you said that any small intervention is very much crucial to addressing the current situation. Now, on to our next question. Will UNAIDS include U equals U in its political declaration? Will WHO include U equals U in its new guidelines? This will definitely be used as a motivation for people to start treatment.
Very interesting question, very pertinent, particularly as we are at the time of the high-level meeting. Just to clarify that the political declaration at the HLM is not UNAIDS. It is negotiated by the member states. And you all know the reality is that we have different positions from member states, from those who are much more engaged and proactive to those who are more conservative. And the final declaration is a negotiated, I would say, one or based on consensus. And this is where civil society and communities play an extremely important role to influence the decision by the countries. Yes, it all refers to the some background, and the background we would say this year would refer to this new strategy, and the strategy clearly makes good references to these elements of U equals U. So I don't think the question is about UNAIDS putting it, but in ensuring that the countries agree on it and that it finds its way to the declaration, or at least it gets adopted, its principle gets adopted by the countries, even if the term itself is not used, but at least its principles and what it means is adopted. That's what is really important in me.
Thank you very much for that. And now on to our last question. In the interest of time, but definitely we're learning so many things about what you have just relayed to us this afternoon, Taufik. Do you think by 2030 we can eradicate the stigma on HIV? How hopeful are you?
I am personally very hopeful and very positive, because now I am seeing practical responses, practical approaches in reducing stigma in its different ways. I'm referring to this group called, this initiative called Quality Improvement, QIS, which aims to reduce stigma and discrimination, particularly in healthcare setting, but it has its links beyond healthcare. And why I like it, why I see great potential, is when I see that it is not based on principles and only wording in saying stigma. What was done in the past is measuring it with a little bit of counseling. But now we see real actions. We see trainings, we see models, we see stronger engagement of community organizations, of groups, communities of people living with HIV into finding solutions jointly with the decision makers, with the service providers. This practicality of the approach is what makes me really hopeful, makes me see it very positively that we will reach some level of reducing stigma. It requires that action. It cannot be put only on policies, not only on service delivery, not only on advocacy. It has to be a joint and comprehensive approach. And when we see models like this being adopted more and more by several countries, and with joint partnerships, I maintain that hope, and I see already improvements. We have the evidence from a couple of countries who are reporting on the measurement of stigma and discrimination faced by the key populations, which is different than the paid HIV. We do see improvements in as short as 2 years of reporting. So 2030, if we continue on that trend, I am sure we will achieve very well.
I am hopeful as well, Taufik, because there are so many things that we have done so far in the last 10 years. I saw how the advocacy has grown, especially here in the Philippines. And as an advocate myself, I am definitely hopeful that together, through the practical and comprehensive approaches that you have just mentioned, we will achieve that. Most especially, we have you and we have our viewers right now who are advocating in the eradication of HIV/AIDS by 2030. Once again, ladies, gents, and gender queers, let's give it up for Sir Taufik Bakali. Thank you so much. And now, on to our next agenda, in which we will be again discussing the expectations for this symposium. I have introduced him a while ago, but I guess it's also a good thing that we started this 2-day session with the setup of the current situation of HIV/AIDS and how we have responded to it here in Southeast Asia. So to give us this symposium's expectations, let's all welcome Love Yourself founder and executive director, Mr. Ronivin Pagdakhan.
Mabuhay everyone from the Philippines. On behalf of Love Yourself and the Filipino HIV community, we truly appreciate you for joining us over the next 2 days for the You Matter, inspiring a client-centered HIV response in the Philippines and Southeast Asia Symposium. As we listen to community leaders, experts, and movers from the Philippines, the region, and as far as Australia, we hope to impart how client-focused approach in addressing HIV is necessary, the way to go. Love Yourself also cherishes its relationship with the IAS Educational Fund over the years. Our partnership has proven fruitful in taking our HIV advocacy to a global scale, making our movement and efforts known to the rest of the world, while at the same time helping us reach more people who share in our vision and goal. Continue fighting against HIV through modern breakthroughs, client and community empowerment. This symposium aims to discuss the main challenges and recent updates on the HIV response in Southeast Asia. During 3 and 4th of June, 4 main topics will be covered during this meeting. First is PrEP or pre-exposure prophylaxis and post-exposure prophylaxis or PEP interventions. Second is stigma around HIV, PrEP, and U equals U. Third is testing and treatment as prevention in Southeast Asia. Fourth, and last but not the least, is self-testing and sharing of best practices from the region. Today, during session 1, we will focus on PrEP and PEP, as we've heard a while ago, including successful PrEP rollout in the Philippines and Australia as study examples. Now, here are some housekeeping rules. All participants are currently muted, but you can ask your questions in the questions and comments box right under this window. I invite you all now to please introduce yourselves by typing in the chat interactive box that is right under the screen, and you will see that your message shows in the interactive box to the right of the screen. Please type your first name, last name, and the organization that you work for, and the country you are from. Please use this opportunity to connect and get to know each other. Please send questions during our speaker's presentation so that we can address anything that you would like to ask during our Q&A parts in the session. We are also pleased to announce that if you participate in our feedback survey at the end of this meeting, you can request for a free 1-year IAS membership. All meeting participants will receive an email about after the very last session of the symposium. Now, we'll launch some introductory polls for you to participate in and let us know how you're feeling today.
Hi, I'm Alan, your transplant blogger from Cebu. And
So we have a 67% rate. Great. Thank you so much, everyone, for participating. And lastly, all our discussions during everyday session will be beneficial to our roles for our respective communities. I hope that this results in the ripples of positive change throughout the Philippines and across Southeast Asia and our neighboring nations in the Asia-Pacific region. Regardless of your role in this fight against HIV, remember that you will be more equipped, educated, and encouraged to do more because you matter. Thank you and have a great day. Over to you, Mela.
now, I'm going to Victoria for my regular
A
check.
very dear friend, Ronivin Pagtakan, the founder and executive director of Love Yourself Incorporated here in the Philippines. Wow, I can't help but be excited as well as I know you are too. So thank you to those who are attending our 2-day session. This is once again day 1 of our You Matter Symposium. And you are attending the very first session. This is all about PEP and PrEP. Now, I know you are all excited. We've heard 2 speakers already. But before that, there is a change of microphone involved so that you can hear me clearly. Once again, the chat box is open for you to ask any type of question or to give in comments throughout our conversation. More so, feel free to introduce yourselves to a network of advocates across Southeast Asia. Now, let me inform everyone, especially our Filipino participants, that this symposium entails continuing professional development or CPD units under the self-directed CPD accreditation scheme. All you have to do is attend all 4 sessions and we will give you instructions on how to claim your CPD unit accreditation. After the 2-day event, an official communication will be sent to your email. Again, you have to complete all 4 sessions to claim your CPD units. And before we proceed to our next session, we will have a 5-minute bio break and we will come back with a segment about PrEP and PEP. Let's watch this. And we are back. You are still with us at the You Matter Symposium, and this is the first session entitled Upscale PrEP and PEP Interventions. I am Ella Habijan, your host for today. Now, on to our next speaker. She is the Regional Advisor for HIV Pre-Exposure Prophylaxis or PrEP, also the World Health Organization and the UNAIDS Regional Office for Asia and the Pacific. At this point, she will be discussing the implementation of PrEP and PEP in Southeast Asia. Let's all welcome our dear friend, Heather Marie Schmidt.
Good morning, I'm Heather Marie Schmidt, the Regional Advisor for Pre-Exposure Prophylaxis with the UNAIDS Regional Office for Asia and the Pacific and WHO. There is a clear need to improve HIV prevention efforts in our region. In 2019, there were 300,000 new infections. 98% of new adult infections were occurring among key populations and their partners, and 1/4 among young people. Pre-exposure prophylaxis as an additional HIV prevention tool has been shown to be highly efficacious, capable of real-world reductions in HIV infections when coverage is achieved at a high level, such as in Australia, England, Scotland, and in parts of the US, and has psychological benefits, including increased sexual well-being and reduced shame about condomless sex. In our region, however, there is a great disparity in terms of PrEP access. Australia and New Zealand, for example, have national programs subsidised by the government. Thailand included PrEP under the NHSO, admittedly as a trial, in 2019, becoming the first Asian country to provide PrEP under universal health coverage. Other countries like Vietnam, Cambodia, and Nepal are scaling up their PrEP programs rapidly with plans for national or near-national rollout. Demonstration projects have now started in countries like Laos, PDR, and Mongolia this year, and Sri Lanka and Myanmar last year, and further countries are in the advanced planning stages. And it's important that these demonstration projects are scaled up to achieve high coverage. And while access is increasing in terms of sites and countries providing PrEP, there has been an acceleration in the number of people who've reported to use PrEP. It falls short, however, globally of the commitment made in 2016 by the UN General Assembly to have 3 million people on PrEP by 2020. In Asia and the Pacific, we account for just 10% of the global PrEP users, and use is not proportional to either country incidence or prevalence or to the population of that country, and is not sufficient to bridge the prevention gap and change the course of the epidemic in our region. And there is clearly an unmet need for PrEP. These are the results of a survey administered through Hornet of over 3,700 participants from 24 countries, the majority of participants from Thailand and Indonesia. Using criteria broadly consistent with the guidelines in the region, including condomless anal sex, having an STI, PrEP use, and/or any drug use associated with sex, more than half of HIV negative and untested respondents may be eligible for PrEP. Critically, of those eligible for PrEP, only 30% have ever used it. So what does PrEP look like in some of these countries? What have been the recent advances? And so beginning with Mongolia, Mongolia's PrEP program was launched just a month or two ago. So it is really very, very new. And so because it's so early, the one thing that I really want to focus on is their awareness raising and campaigns, which is such a critical component of successful PrEP programs. So they have used digital platforms for online awareness raising and information through the Test for UB website. And that you can that's also used to book appointments, and they've had over 120 people sign up or make reservations through that website. What is also key about this is that they've strengthened the linkage between testing and PrEP by using the same platform to generate demand for PrEP and for testing, including HIV self-testing, making sure that the linkage between those two programs is quite strong. Moving on to Cambodia. Cambodia launched their PrEP program in mid-2019, so it's also a relatively new program. But what I really want to highlight about the Cambodian program is their approach. So rather than a demonstration project, Cambodia started off with phased implementation. So they had a plan to scale up and started off small at one clinic. And they are constantly adapting their response as they're scaling up. Their plan is to scale up by 2023 to reach at least 5,000 people in 15 high-burden provinces. And you can see that the number of people who are accessing PrEP has increased rapidly. Just a year ago in quarter one 2020, there were just over 200 people who are accessing PrEP. And by the end of March 2021, this had risen to over 900 clients accessing PrEP, which is quite a substantial achievement given the COVID-19 pandemic. In 2020, Vietnam's PrEP program dramatically expanded to over 18,000 PrEP users, over 10,000 more than in 2019. And this is despite the COVID-19 pandemic. Civil society and innovation are hallmarks of the Vietnamese PrEP programs, with key population-led clinics being an important delivery point for PrEP. To protect PrEP programs during the pandemic and to ultimately support this scale up in Vietnam, they took a number of steps, including online counseling, PrEP drug delivery, home sample collection, and this included blood-based HIV self-tests, and having a community task force for rapid information on COVID-19. And this was particularly effective during the lockdown periods. Vietnam's 5-year scale-up plan was approved in December 2020 and aims to provide PrEP to 72,000 individuals. This sets a new benchmark for the scale-up and speed of PrEP rollout in our region. So what's next? The adaptations and innovations used during COVID-19 that have proven successful must become the new normal globally in PrEP programs. And as the pandemic continues, this is becoming increasingly likely. And we need to plan for the introduction of new PrEP products and dosing regimens. And these will include long-acting cabotegravir, which completed phase 3 trials last year, showing excellent efficacy, as well as the dapivirine vaginal ring, which received a conditional recommendation from WHO in January this year. There are other PrEP products that are in the pipeline and in phase 3 trials, including monthly pills, extra-long injectables, and PrEP implantables. All of these products will offer choice and overcome potentially some of the issues associated with oral TDF-FTC or oral TDF-3TC, particularly daily oral. And this may include effective use or appropriate adherence. But each of these products will have their own new challenges and unknowns, including efficacy in the real world, testing, drug resistance, and of course the important question of cost. And in the meantime, WHO is working to simplify our guidance on PrEP. We're looking particularly at things to make it simpler to implement and to expand our PrEP access. And these include things like looking at starting and stopping rules, looking at effective adherence, behavioral screening and eligibility, looking at demedicalization of our service delivery models, as well as differentiated service delivery, and streamlining our monitoring and evaluation, support for informal use, and considerations of those pipeline products I mentioned. And before I finish, a quick word on PEP. We know that access to and uptake of PEP is suboptimal among those who need it. Particularly for non-occupational exposures, there can be prohibitive costs and limited availability in many countries. We know that adherence tends to be poor among those who take it, and so there is a need for new regimens of dosing or new drugs, and there are some promising drugs in the pipeline that may need to be considered. But PEP is particularly important also as a bridge to PrEP, and I think that this hasn't been emphasized enough. We need to make sure that PEP is easier to access and use some of the learnings that we've had from PrEP around demedicalization and differentiated services, perhaps making PEP more easily available in places like pharmacies to increase access among those who need it. In Asia and the Pacific, we've made some significant progress in increasing access to and uptake of PrEP, particularly over the last year, and that is impressive given the disruptions from COVID-19. However, the progress is far from being even and far from being complete, and it is just too slow to yet change the course of the epidemic. The priority must now be to increase access and uptake in all countries. And to do that, we need to look at what's working and what is missing. And we need to put the individual at the center, taking a person-centered approach that disrupts the traditional models. And these have been particularly effective in the Philippines, Thailand, and Vietnam. We need to simplify the models of care and delivery, and hopefully the upcoming WHO guidance will assist with this. We need to differentiate, to demedicalize, and to integrate services, and you saw examples of that with the adaptations for COVID-19. And we need to make sure that they're available whenever and wherever a client needs them. And we need to expand digital innovations which offer choice and convenience and confidentiality in a way that offline services can't always do. And there is a lot to do, but we have the tools available. So let's get PrEP and PEP done. Thank you to the organisers and to all of my colleagues in UNAIDS, WHO and other organisations who contributed to this presentation.
Thank you very much, Heather Marie, for giving us substantial insights into the PrEP and PEP landscape in Southeast Asia and the world. I believe the information you have just given us could actually amplify and strengthen our HIV prevention into a more aggressive region that we already are. And soon enough, I know that we can achieve that dream by 2030. And to those who are watching us right now, again, if you have any questions or comments, kindly write them down on the interaction box, and we will have a question and answer portion later after our next speakers. Speaking of which, to talk about the successful rollout plan of PrEP in their respective localities, I am pleased to introduce to you two of our PrEP champions. The first one is from the Philippines. She is representing the Philippines Department of Health Research Institute for Tropical Medicine. She is none other than Dr. Rosana Ditanco. And the other person I'm talking about is the Theme Director of Populations and Prevention and Head of the HIV Epidemiology and Prevention Program of the Kirby Institute of the University of New South Wales in Sydney, Australia. This is Sir Andrew Grulich. Sir Andrew is also a member of governing council member of Asia and the Pacific Islands of International AIDS Society. Dr. Ditanco will be the first one to talk, and she will be followed by Sir Andrew. Dr. Ditanco, way to go. You may now start your presentation.
Good day to all. I would like to thank the organizers for giving me the opportunity to share the Philippine experience on PrEP. Being one of the few countries in the world reporting more than 50% increase in new HIV diagnosis for more than a decade and low condom use, it is quite apparent that PrEP should be part of comprehensive strategy of HIV prevention in the Philippines. Building on the success of a community-led HIV prevention, testing, and eventually treatment services that the Research Institute for Tropical Medicine, or RITM, helped establish with the Love Yourself Foundation, it was thought that a similar model of a community-led, peer-driven PrEP delivery will be a good strategy to introduce PrEP in the country. This demonstration project led by RITM, the Love Yourself, and World Health Organization Western Pacific Regional Office, with support from the Philippine Department of Health, the Global Fund, and AMFAR, became the basis of the policy on PrEP use in the Philippines. So in June 2017, to determine the acceptability and feasibility of PrEP use, 250 MSM and transgender women in Metro Manila, Philippines, with substantial risk for HIV were enrolled and given daily PrEP consisting of fixed-dose combination of tenofovir and emtricitabine for 12 months. We were also interested on new HIV and STI infections during PrEP use, as well as the change in the frequency of condomless sex, use of drugs, and the number of sex partners. In spite of the limited social media promotion of the project, still there were 3,000 MSM who expressed interest to participate. We found that there was zero new infection during the 2 years of the project. The project ran for 2 years. Actually, the first year is per protocol, and there was another 12 months for opt-in to continue PrEP for another 12 months. Also, the number of new cases of STI, such as syphilis, gonorrhea, and chlamydia, did not increase. And there was 80% was still taking the pill at 3 months, which is a WHO benchmark for adherence. We also found that there was an increase in the number of sex partner in the past 6 months. Anal sex with casual partner, though, decreased, and there was a decrease in the condom use observed during sex with steady partner. Did this data suggest that MSM would want more pleasurable or condom-less sex with their sex partner in a safe way? We also observed that there was a decrease in condom use while drunk or high, which is really not unexpected, an increase in the use of mind-altering drugs. Although we saw this, but majority said that it is extremely unlikely that drug or alcohol will affect PrEP use. Again, did our data suggest that our MSM could and would like to party and play safely and responsibly? In conclusion, we could say that PrEP introduction in the Philippines was successful because of the high interest generated, and it became the basis of the policy of PrEP use in the Philippines. Currently, PrEP is available for free in limited facilities with support from our international partner agencies. Although not yet widely available in commercial drugstores, it is already available for the private sector use. Thank you.
Thank you, Rosanna. I think that's me now. So my name's Andrew Grulich from the Kirby Institute in Sydney, Australia, and it's a real pleasure to be with this esteemed bunch of presenters talking to you a little bit about the way we introduce PrEP here in Australia. And the story goes back to 2016 when the results from the large randomized trials in Europe and North America really demonstrated that PrEP was an incredibly exciting new preventive intervention. And I think that's something that we sometimes gloss over. But, you know, I'm old enough to remember the period before 2010 where all we had to prevent HIV were condoms. That's all we had. Now we have one pill once a day, which is virtually 100% effective in preventing HIV. I think when you start from that position, when you start from this fact that we have a virtually 100% effective intervention, we really should be rolling this out with a sense of excitement and a sense of what we can do to end the HIV epidemic. So we started this in 2016 with high ambitions to roll it out at scale, so that it was the benefit certainly of the individuals taking it, but as Tafiq was mentioning earlier, we were also wanting to take advantage of herd protection, because if we could disrupt enough chains of transmission, then we would see declining HIV at the population scale. Here in my state, in New South Wales, we started in roughly 10,000, mostly menorexic men on PrEP within about 2 years. And over that period, we saw a 30% decline in new infections statewide. That decline is now larger than that. Countrywide, it's now approaching 40%. And we know that in parts of the country, particularly in the inner cities, that the gay community is well organised, and we've had gay community organisations do a lot of PrEP education and demand creation. In those settings, we're seeing declines in HIV, which are 60 to 70%. So we are beginning to see some disparities in who's taking PrEP up, and this is a bit of a theme around the world, that more marginalised populations are somewhat less likely to take HIV up. And this is something that we in Australia are trying to address now, and around the world you see that pattern. A couple of other factors that I think underlie our successful rollout in Australia is that we did have fantastic leadership from government. Government could see the excitement of this new therapy and were there all the way in supporting and expecting us researchers and the community organisations to work together to make this work. I do think even in settings where the government is not as excited about this, our community organisations can be. And I think fantastic organisations like LoveYourself that are led by members of the affected populations have an incredibly important role to play in East and Southeast Asia, where stigma is very high, but organisations such as LoveYourself are fantastic, I think, at fighting stigma, and therefore can help educate and create demand. I think I would mention something that Rosanna brought up was pretty good in the Philippines rollout, is that attention really needs to be paid to adherence. People do need to understand that unless they take the pills according to prescription, they won't be protected. So it's not good enough just to get people taking PrEP. We have to ensure that they keep taking PrEP when periods are at risk. And I'd just like to wrap up in saying that, you know, because we have 100% effective intervention, if we can scale this up, we can make an enormous impact on the epidemic. So we should aim high. And I'll wrap up there. Thank you.
Thank you very much, Sir Andrew and Dr. Annie, for those insights that you have just relayed to us. But please stay as I now call on our earlier speakers, Dr. Heather Marie and Dr. Ditanco, for our Q&A with our symposium participants. But first on the list, let me just ask you how you are this afternoon. I am feeling your great energy right now. Let's begin with Heather.
Hi, it is great to be here to talk about something that I am incredibly passionate about, which is increasing uptake to and benefits from PrEP. So I'm really happy to be here, and particularly with all of you and my colleagues who are amazing and are doing amazing work.
Let me just say you look wonderful this afternoon. So I'm so excited to see you again. Now on to Doc Annie. Doc Annie, kamusta? How are you feeling right now? Okay, while we are waiting for Doc Annie's response, I'd like to ask Andrew. Andrew, how are you? You're coming all the way from Australia.
Yes, and look, it's a gloomy, rainy afternoon here in Sydney, but it's like Heather Marie. I'm really excited to be here. There is such potential in rollout of PrEP. You can probably hear my excitement in my voice. It's done a lot in Australia. We've got a long way to go, but through organisations like LoveYourself around the region, I think there is huge potential for changing the lives of key affected populations. And one thing I would say, it's not just about preventing HIV, it's about freeing people from the fear and the anxiety around catching HIV. So it's a really positive intervention in people's lives.
Well, that is so good to hear. Just really being in your presence as champions of PrEP and you updating us on the current situations on Southeast Asia, the Philippines, and of course, Australia, which, by the way, is the very first country to have a massive rollout of PrEP in a specific country. I'm very much interested on where we are taking the conversation. Doc Annie, how are you?
Hi, can you hear me now?
Yes, we can hear you right now.
Okay, I'm fine. Feeling good. Hope you
Maraming
are
salamat.
all too. Yeah.
Appreciate
Mabuhay from the Philippines.
Yes, mabuhay from the Philippines. And your smile right now, Doc Annie, is very, very infectious. So now let's begin with our question and answer segment. Let me begin by asking Heather Marie, with the current trend on PrEP uptake, how can we make governments sustain their programs and be able to achieve zero infection by 2030 alongside the 95-95-95 mission on treatment?
So that's a big question, and it's what we are trying to do. But I think there's a lot of factors really to consider, and the thing is that we have evidence. We have a lot of really good evidence for how effective PrEP is. Not only do we have the evidence for how effective it is in reducing infections on a population scale as well as an individual scale, we also have, as Andrew mentioned, the information on the psychological benefits of having PrEP for individuals and for society. The things that we need to really concentrate on here is, I think, really getting government to there's a role for getting government to really believe in the benefits that PrEP can bring over and above just just ending HIV, which is a massive thing. But there are economic benefits that PrEP can bring in terms of increased well-being, in terms of reduced infections, reduced attention, reduced resources that need to go towards future infections. There are, so it's really about looking forward to the future around, it's not what PrEP can do today, but what PrEP will have, the impact that PrEP can have. There are other things that we need to look at, of course, and one of the amazing things that's happening in the Philippines and in many other countries around our region is that community organizations have been incredibly important to really rolling out PrEP, to making it available, to letting people know about it. And this has demonstrated that people want to take it. People want this option that's available. And so I think that that's also encouraging for government to know that there are, people will use it, and overwhelmingly people also use it pretty well. There are studies that have come out from other places that show that people are increasingly able to recognize when they need it and when to take it. There are things that we need to do in terms of costing to bring down the costs, and that's where demedicalization really comes in, and simplifying PrEP, so that we're really focusing on the things that you need to do to make sure that PrEP is available, and integrating PrEP into a broader range of services so that it's a much more efficient option. And I think some of those things in terms of simplifying PrEP and recognizing these benefits from PrEP really do help to embed them going forward.
Well, definitely just hearing about the things that have been done in Southeast Asia as you have presented, it is giving me hope as a person. And I really do believe that if there are more people who are participating in the rollout of PrEP, we can be prepared. PrEP is for preparation for an HIV-free world. And that being said, we would like to encourage everyone who is watching us right now to kindly type in your questions to our speakers. Our speakers are very much open to answering your questions right now, and hopefully they could give you clarity to the things that you want to be addressed this afternoon. But as we await for our questions, let me ask this question to Dr. Ditanco, because we've seen a while ago, according to the data presented by our speakers, Australia, Thailand, and Vietnam are the biggest countries who have done massive rollouts in their respective countries. I'd like to zoom in our case here in the Philippines. How can our government support a massive rollout of PrEP in the country, especially that our country has again been reported to have been the fastest growing HIV epidemic in the APAC region?
The Philippines is in a unique situation, and I don't think we can just centralize PrEP service here. And the local government units really play a big role in terms of supporting PrEP delivery. But basically, what I think what is really needed is that program managers, implementers, advocates should really the first thing that they have to do is really come up with a creative, realistic, doable plan that could be rapidly rolled out and sustainable, and then be able to present this to policymakers or whoever would be supporting, deciding on policy and funding support, and also take in consideration the intention of these policymakers, so that they have different intentions. If this is not aligned with their personal interests or their political ambition, then it will not go. So we really need to do a sort of lobbying and PR work here, so that whatever is the interest of the stakeholder will be put into consideration, so that they would buy into the program. Because funding may not really be a problem, because it is a matter of resource mobilization. I don't think funding is really, there's really lack of funding here. It's just being able to tap the right resources. And sometimes we need the support of our leaders and our policymaker to be able to mobilize these resources. So, we really have to be able to tickle the interests of key people here so that they would buy into the program. But to begin with, come up with a realistic, doable program that would be rolled out rapidly and is really sustainable.
Sustainability is all stemmed out from creative, realistic, and doable program. I am with you, Doc Annie. So if you need help, I'm here. Nandito po ako so that I can advocate the prep rollout here in the Philippines. I am with you. Now, on to our next question, and this can be answered by both Heather and Doc Annie. Here it is. Do we have cost-benefit analysis studies on PrEP in the Philippines or any countries in Asia and the Pacific region? Can you tell us about it? Is offering free PrEP cost-effective? Let me begin with Heather.
So we do have an upcoming study that will be released on cost effectiveness, not necessarily cost benefit. And what it really, from memory, what it shows is it really is favorable towards the benefits of PrEP in terms of costing. So that is that study hasn't been released yet, but will be coming. There are also country-based studies in several places, but they're only as good as the inputs that you put in. And one of the major drivers has always been in these cost effectiveness analyses has been the cost of the PrEP drug. And historically, the cost of the drug was very high. And that has come down dramatically. So really, a lot of the concerns that were initially raised about cost effectiveness in terms of the drug have been dispelled, and the benefits tend to really speak for themselves in terms of the potential to prevent infections and those downstream cost. I'm not going to say cost savings because I can't remember whether it was cost saving, but there's cost, the effectiveness downstream was quite good.
Definitely. I guess it's really the law of supply and demand being applied in here. So the more people who are actually using it and as the need arises, I guess the cost will really, really go down. How about us in the Philippines, Doc Annie?
Well, there's no study on that, but as Heather said, the cost now of PrEP is very, very affordable, and even without, personally, I think that even without a cost effectiveness or cost efficiency study, but of course that will be good because of the dropping cost of PrEP, most likely it will be cost efficient. But I would just like to add that, PrEP is not the only prevention intervention. Combined with treatment as prevention, and all of these are done on a scaled up rate, and we will be able to achieve the so-called herd immunity. I don't think people will be on PrEP forever. So it is not something that you take forever, unlike treatment. So, and I believe after 3 or 5 years, people will change behavior and they will have maturity, and perhaps choose other prevention intervention for themselves. So I think overall, really, PrEP is something that is cost efficient.
Thank you very much for that insight, Doc Annie. Yes, it is cost efficient more so. It will be one of the ways in which we can prevent HIV. I like how you highlighted a variety of things that we can do here in the Philippines. Now, let me ask Andrew. Australia is such an idol in terms of PrEP rollout. How can we replicate the massive rollout of PrEP in the Asia Pacific region, particularly those countries who have limited resources and with increasing incidence of HIV?
So thank you for the question, Mela. You know, every country is different, and so I don't think I can say with my hand on my heart that that anywhere else would be exactly the same as Australia. But the fact is that wherever you are, this is a 100% drug, effective drug when it's used as prescribed. So anywhere that uses it at high level is fantastic effect. And I absolutely agree with Heather Marie and Annie. This is highly cost effective. But countries in Africa are some of the highest PrEP using countries in the world. South Africa and Kenya and other countries are using this at very high levels because it's cost effective. Because the cost of a generic drug for a few years, and it might be 3 or 5 or maybe even 10 years of a person's life, compared to the cost of losing people's lives to AIDS, or by providing lifelong complex care of people with HIV and the second line treatment. This is, we need to let our policymakers, this is a no-brainer. This will save countries money, and we should be getting on with it with no delay.
Can you still hear me? Because right now, we are doing this live. So to all our audiences who are watching us right now, I will be back on video soon, but definitely the show is going on. Just listen to my voice right now. And now I am back. I hope you can still see me. I am still with you. I am bringing you my most beautiful smile at a time in which we lost battery for the camera. But then again, I love how our discussion is going forth this afternoon. Thank you so much, Andrew, for highlighting the fact that it can be done and it should be done right now. We have a goal, and that should be manifested in our simple steps as we take on the 2030 free from AIDS world. And now, I do wish that we could have a longer period, but sadly, we only have a limited time for our segment. So I would like to thank you personally, Doc Annie, Heather, and Andrew. Thank you for joining us this afternoon. Definitely, the things that you have relayed to us are information that we can use so that we can effectively roll out PrEP in our respective countries. And before we end our first session, may I call in once again the founder and executive director of Love Yourself, Ronvin Pagtakhan, to conclude our first session of Scale PrEP and PEP intervention. Vin, kindly take the floor.
Thank you, Mela. Thank you so much for hosting. And hello, everyone. It's so exciting to see you all again. And thank you, each and everyone, for making You Matter Symposium Session 1 an undeniable success. It's a dream to gather an incredible pool of research speakers, volunteers, and community leaders in a virtual event like this. I'm eternally grateful to guest speakers who enlightened us about how our fight against HIV continues to transform, and that particularly at a time that has been challenging and demanding to all of us, individually, as a community, and as a region. Not only did you educate and update us, but also gave us hope that with the help of scientific advancement and anchored with genuine concern and care for our clients and community members, we remain in pretty good shape towards our goal to improve our HIV response and advocate for education and elimination of stigma. May you all learn more during our next sessions. I will see you again tomorrow, and thank you so much, and keep safe.
Thank you very much, Vin. As you have that positive energy as well as our speakers, I am so boosted right now as we keep on our symposium, You Matter Symposium, in the next 2 days. Again, we still have 3 more sessions that will be coming up for everyone. This has been Session 1, Upscale Prep and PEP Interventions. My key takeaway right now is that number 1, we have so many things that we can do. A simple step can actually contribute to the alleviation and towards our achievement of really eradicating HIV and AIDS in our world by 2030. 2, PrEP is one way to do so. From the variety of options that we have, PrEP is one powerful option that we can all promote in our respective countries. And hopefully, we will have the national governments of our respective countries participating in our endeavor. And right now, we will be having a 30-minute break before we move on to our session 2, and that is Understanding and Unity Against HIV, which will be moderated by Sir Iskandar Azwa. Thank you to all the participants who have asked questions to our speakers. Thank you for your excitement for our symposium. Your presence is actually making this event a success. We all hope you enjoyed this session. We would like to thank our partners for this afternoon. That is Viv Healthcare, Merck Shop and Domi, Gilead Sciences, and the Swiss Agency for Development and Cooperation for their support for this virtual meeting. And really, we made this possible. We will be back at exactly 3 p.m. Manila time. But in the meantime, please watch all the videos of IAS and Love Yourself about the HIV advocacy and many more. Once again, I am your Miss Trans Global 2020, a proud advocate of HIV/AIDS here in the Philippines. My name is Mela Habijan, and I will be seeing you again tomorrow for sessions 3 and 4. See you again soon. Bye, and enjoy your 30-minute break.